Well, good evening, everyone. Welcome back to our Exam Pro webinars for today, Tuesday, August 2nd, 2022. I'm your host again, Rob Pegues. We are starting into our first August session of case list review now instead of case list prep, since today is the initial submission deadline for the case lists. I think everybody is okay again with our audios, everything, but yes, I'm just going to do this really quickly. And I would like to go ahead and get our case list up, which I think I have right here. There they are. We got case lists for, this is everybody who sent them in as of, I believe, about 4 o'clock this afternoon. So let's start in right away. Any one of you would like to raise your hand. We'll spend some time and we'll be happy to talk about anything on the case list that any one of you would like to speak about. We can go over cases that you have concerns about. We can practice just doing a simple, maybe 7 to 10 minute mock oral or less on a case at random. I'm also happy to talk about just anything else that sort of comes up on as far as the case list, as far as basic topics. But we would like to get as many of our candidates this evening to have a little time just to practice in just a teaching mock oral format. So please, any one of you who would like to step up. And again, if for those of you who have not yet sent in your case list, that's perfectly okay. I have the case list here over on the left-hand side for 11 of our candidates who are on the August series, and we can go look at their case list. For those of you who have not sent it in, I'm very happy to talk with you. We could, if you can just present a case, or if you have something at the side to just to tell us about, I'll be happy to talk about that also. So you do not need to be a candidate who has a case list up on the screen here. So anyone who would like to talk to start off, or I'll just pick somebody maybe. Let's see. Let's check in at the top of our list here for just a second. Let me check in with Dr. Buttigieg for just a second. Emily, if you would like to speak, since you, I believe we have your case list up here, if you'd like to unmute yourself, we can get started right away.
Sure. Can you hear me?
I can. Yes. Thanks for joining us. Here, let me pull up your case list. Thanks for jumping up here. All right. I have everything here. Any place you'd like to go? OBGYN or office?
Probably let's do GYN.
Pardon me?
Let's do GYN.
GYN, sure. All right. Here is. Sorry, I'm going to get your GYN case list up. There we go. All right. Got it. Let me just move out of the way so I can navigate your case list here for just a moment. Just a second here. Thanks. All right, good. All right, any particular case on here that you'd like to chat about? Or I'll pick something at random if you'd like.
I'm trying to think. I can't think of one right now. It's a longer list. I'm still working through learning. It's a long year.
That's okay. We're still submitting cases. That's fine. I think there's something useful here. The examiners really look at page 1 of the case list, and particularly I think on GYN, and there is something here I think it would be useful to talk about for a few minutes. Sure. Because I noticed here that you've got a number of hysterectomies, and we got TVHs and TH, and you're doing cystoscopies on each one of them. Yeah. And the examiners are very fond about talking about this, and they would ask you, so in your practice, how do you view cystoscopy? Is this something that you do routinely on all of your hysterectomies, or would you do it in certain cases based on sort of concerns or outcomes for the procedure?
Yeah, so in my practice, I do practice in an academic setting, and so as a group, we all do cystoscopies routinely on all of our hysterectomies. But, in practice, it's not, you don't necessarily have to do cystoscopies with every hysterectomy.
No, that is true. So if hypothetically you were out in practice then, and we're actually managing hysterectomy cases, under what sorts of cases might you choose as cases in which you might actually do a cystoscopy?
Yeah, so I would do one, in a case where there was a lot of adhesive disease, where I was performing lysis of adhesions, any case where there was, significant endometriosis with distortion of the anatomy.
Good. Great. Anything else that comes to mind, this as far as sort of the reasons why we do hysterectomies, sort of based on what your case list here? Anything for which you might feel a little bit more of a leaning to do a cystoscopy?
Well, the risk of an injury is a bit higher when you're doing, I'm trying to remember, I believe it's the vaginal that has like the most likely of a ureteral injury, but I'm having to remind myself. So I guess
No,
we can both look at.
that's where I wanted to come to. I wanted to bring this up because many of our candidates actually, when this comes up on the exam, will discuss it based on the route of approach to hysterectomy and their appreciation of some of these being sort of higher or lower. Can I ask you
Yep.
though about case number 1 here on your list? This is a 3,860 gram uterus.
Yep.
Um, does the size of the uterus actually factor into your decision as to whether to do a cysto in a hysterectomy case?
I imagine it can. I mean, the size is going to then distort the anatomy, as I was kind of alluding to beforehand. Obviously, this was not a normal looking uterus by any means, and so
No.
that in and of itself could warrant doing a
Yeah.
cystoscopy.
Good. Is there anything about sort of the placement of masses or myomata within a uterus that might also make you more likely to do a cysto?
Yeah, if there are any cervical ones, then I definitely would, since the ureters are really close at that point.
Sure, that is true. Sure. Anything else we run to as far as sort of where myomata are that might be a factor here? That's a good example.
I guess any in the broad ligament itself.
The interligamentous myomas, good. That's right. So in the exam, what we would always recommend is if you're asked about this, and if you're a universal cystoscopy person, as Emily is right now, that's perfectly fine. There's no points taken off. They may hypothetically ask you, and if you are a person who is not a universal cystoscopist, here's the pitfall in the exam: is starting to talk about it based on the route of approach to hysterectomy, and sort of when we think about TAHs, TLHs, TVHs, LAVHs, which are the higher and lower risks here. I think it is
Hmm.
always best to discuss it, as Emily is, based upon your appreciation of the complexity of the case, and
Hmm.
sort of your access to the lower pelvis where the ureters are, and the likelihood of either getting an instrumental injury or a thermal injury if we're talking about the TLHs in these cases.
Yeah.
What Emily
Okay.
brought up was very important because there is a widespread impression out there that the highest risk of ureteral injury is with TVH. And in fact, if you go back and look at the literature and open any surgical gynecology textbook, what you will find is that TVH is the case that is associated overall with the lowest risk of unrecognized ureteral injury at surgery. And the highest is, of course, the TAH, because that's where
Mm.
we open them, because they're the really complicated cases: adhesions, big masses, previous surgeries, malignancies, stuff like that. The
Mhm.
TAHs are the higher risk of lower urinary tract injury that might not be recognized otherwise unless we did a cysto, and the TVHs are the lowest, which is the
Mm.
opposite of what we sort of talked about a few minutes ago. And then in the middle are the laparoscopic ones. And the
Mhm.
trick here is, and we want to be careful about this in the exam, is the issue about the laparoscopic hysterectomies, because laparoscopic hysterectomies have a higher risk of lower ureteral tract injury than TVHs. But the question is, would doing a cystoscopy actually help you to recognize that? Because with a TVH and a TH, these are direct instrumental injuries. The basic three types of injuries to the ureter are: you can suture it, you can crush it or clamp it, or you can transect it. But we have with TLHs and LAVHs this whole new modality of ureteral injury, which has to do with indirect thermal injury.
Right, and so that's gonna be delayed. Yeah.
That would be delayed, and we would normally not pick it. Would usually not that pick that up unless it were a really bad injury, in which case you could probably see thermal injury right there. But
Mm.
the pitfalls are that the TVHs are actually by standard research the lowest.
Mm.
And in the exam, it often slips out of our mouth that they're highest, and that's not. The TAHs are the highest, and in
Okay.
between are the laparoscopics. But there's the thermal injury issue, and what we do want to let the examiners know is immediately, so we really know that cystoscopy doesn't necessarily help us. We might do it, but we would still have a high index of suspicion postoperatively if we were concerned about a thermal injury. They turn out 24, 48, 72 hours out.
Right.
Uh,
That makes sense.
that I think is the nugget summary of how we should discuss cystoscopy in the examination. If you're a
Mm.
universal cystoscopist, it's a really easy discussion, and Emily's
Yeah.
done. For us universal cystoscopists, I would expect the examiners would make it a hypothetical issue and say, well, if you weren't, how would you select for the case? And you go exactly where Emily went, which is discuss it based on the issues that present in the case, the complexity, and why we're doing the case in the first place: scar tissue adhesions, bad endometriosis, large adnexal masses, myomatous uterus, large previous surgery, concern for malignancy, that kind of thing. Those are the really important things to bring up. I would stay away from route of approach to hysterectomy unless you make it clear TVH is the lowest, TAH is the highest for unrecognized urinary tract injuries. Good. Emily, thank you for going through that. I thought that was really important to get out there. We always bring this up in
Yeah.
our course.
Oh, that's super helpful. Thank
When we
you.
when we bring it up in the courses, it is surprising how everybody goes the same way. They've got the TBH thing flipped backwards. Thank you,
Yeah.
Emily. That was great. That was a good start off for the evening. Thanks. Let's slip back on Emily's case just here for just a second. I think I can do it like that. Good. There we go. Let's see. We've got lots of time left in the hour. Please raise your hand if you would like to just talk about anything on your case list, or we'll grab one of our other candidates, maybe just a moment. Let's see if we can maybe talk with some of our candidates who did not participate last night, because we did get several people to have good discussions last time. Let's see here. Oh, thank you, Matthew. Good, Matthew participated last night. Matt, thank you for stepping up. I'm trying to unmute you. If you just click your audio button, I think we'll be good there in a moment. Matthew, there you go. Oh, hey, thanks. Welcome back. Let me pull your case list here right now. All right, ready to go. You get to pick OB/GYN office, anything particularly you'd like to talk about.
I guess let's do office because that's typically the weakest.
Okay, sure. There's I got you. Got your office right there, I believe. Me too. Yep, that is you in that office. Good. Just as you've been looking through your office practice, is there a particular topic or case that you would like us to take a look at?
Particularly not necessarily so. The main thing is with a lot of when I list well woman exams, the treatment column also includes age appropriate screening or counseling or something like that.
Yes.
Does it, I guess we have to know very much the primary care sort of aspect of it, of thyroid screening after I think it's 45 and diabetes screening. Is that a fair game?
Yes, starting about 6 or 7 years ago, primary care entered the exam, and it is an office practice. And our candidates from the past couple of years are telling us that maybe 1/5 to 1/6 of this 30-minute case list review actually now is primary care topics. And we should be able to discuss very briefly, if asked, just as generalist in OB/GYN, how we might pick up on maybe a routine exam, a patient who has hypertension, unrecognized hypertension, diabetes, thyroid disorders, cholesterol lipid diseases. For GI, it'd be sort of GERD, peptic ulcer disease, irritable bowel. I think for neurologic stuff, it's usually differential diagnosis of headache. Pulmonary would be pretty much asthma. And renal stuff is often sort of stone disease or things like that. But there are about 10 topics in there. We should be able to discuss briefly how, just if we suspected how in a history and a well woman exam physical visit, we might pick up on whether the patient had that. How would we test or investigate it? For suspected hypertension, what's the basic workup? How do you find out if somebody's a diabetic? What's a hemoglobin A1C and a glucose tolerance test? What's a cholesterol lipid panel? What are pulmonary function tests and how do we use them? That sort of thing. And then medication management is really first level stuff. So what are the bottom 2 medications that are used for hypertension? What's a sulfonylurea for diabetes? What is a statin and how does it work for cholesterol? We talk about for asthma, beta agonists and inhaled corticosteroids. We should sort of have a chart made up so that for the 10 to 12 most common things, including thyroid and things like that, we could run through very quickly how we'd work it up, basics of testing and analysis, first line medical management, and then we would be passing off to a medical internist. But they could throw any of those out there, you're right, under primary care. And it's good to spend part of our office practice pre-preparation time for the exam practicing that stuff, because many of us don't have primary care on the case list. But that's where they go, and that's, as we understand, is what we need to know to very quickly discuss that. And our candidates year after year have told us that each year there's a little bit more primary care creeping into the exam. It might be up to maybe 1/5 or a little bit more now. But the candidates also say that just with that simple preparation, they did not find the discussions to be in any way difficult in the exam. And I think you should have that, make that encouraging. But you're right. The other thing we should know is adolescent and adult immunization schedule. So for case number 1, they would ask us, well, tell me, so, what immunizations do you check to be sure she's up on? And we do need to know the pneumococcal vaccine over age 65. So she's not quite there yet, but the new Shingrix vaccine, shingles over age 50. We need to know basically the MMR, the Tdap, things like that. So for a patient of any age, just sort of how we would discuss basic immunization schedules, that's important too.
Okay.
So with that, Matt, is there a case you'd like to spend a few minutes talking about? We can do preventive care of well women, or we can pick something else.
I guess there's something a little bit further down. I'm trying to remember. Oh, I have a fair number of patients with both PCOS as well as genitourinary syndrome of menopause. So those are kind of my two big groups for me, that even in other categories have this sort of thing. So I guess we could possibly delve into those kinds of things. Yeah,
You've got, actually, it looks like you've got that on case number 1. So I'd just go there.
okay.
They tend to inordinately to pick case number 1 in the 30 minutes. So let's do it. So that's a 63-year-old. So now here I'm interested in that you sort of put the diagnosis here. The problem is usually what the patient presents with. So did she present with an established diagnosis of GSM, or was this how you worked her up?
So this was a patient with known atrophic vaginitis, and she did not necessarily come in with that specific diagnosis, but I believe that was due to her previous provider not knowing the new terminology.
That's fine. So let's work with that. So and this woman comes in and she reports this. Can you tell me very briefly, then, a history and physical exam, how would you begin to evaluate who comes in, not necessarily reporting any symptoms, but just says, my doctor told me I had this?
Okay.
How would you check to see what the status of it is at this time based on history and physical exam?
Oh, okay. So in this postmenopausal patient, she had initially seen a primary care provider for vaginitis, and she stated that she does have, on history taking, she does have chronic vaginal itching, intermittently worse at times, has also had some issues with dyspareunia or pain with intercourse, and has previously trialed some topical or has been counseled on topical estrogen creams, but previously declined them. At which point I had a suspicion for genitourinary syndrome of menopause, given the patient's age and previous diagnosis, as well as her symptoms. And a physical exam with a sterile speculum was performed, noting mucosal or epithelial atrophy, pale mucosa of the pale vaginal mucosa, and thinning of the fat pad. And so at that point, I had confirmed the diagnosis of genitourinary syndrome of menopause. She had declined any STI screening, so I did not have any concerns for any like chronic cervicitis or anything like that. And so we had discussed treatment options for her.
Good. If you've diagnosed this as sort of atrophic vaginitis or GSM, is there any other testing you might want to do at this visit? Is there anything that she might be sort of predisposed to as far as sort of issues in the genitourinary area, other than directly having this condition itself, for which you might want to check out briefly?
Sure. So we had discussed, in addition to STI screening, we had also discussed ruling out vulvovaginal candidiasis, urinary tract infections, given that postmenopausal patients are typically predisposed to that due to shifts in the vaginal flora. And she had declined that as well, in addition to the STI testing.
Good. Yeah, I would want to hit the colonization or carriage with candida, vaginal bacteriosis, UTIs, because they're certainly a risk there. So then I notice here that she declines topical estrogen. Just very briefly, sort of stepping out of the case, do you recall why it was that she declined topical estrogen?
She associated topical estrogen with systemic estrogen, and she had some significant concerns regarding that.
Good. So given that we might want to treat her if she has actually this condition and she will not accept estrogen, what other treatments might you discuss with her?
So there are several other treatments. There's expected management for her. I think she had decreased her sexual activity voluntarily, not in relation to this. So she wasn't all that too concerned about, resuming intercourse or the dyspareunia aspect of her consideration or her complaint. Like it says there, we discussed topical emollients with like a small amount of Vaseline on her external genitalia to decrease friction and irritation and allow for skin healing of any pre-existing excoriations or small lacerations that might be present, of which I did not visualize any on exam. But and then there's also several other kind of less successful measures. She would not be a candidate for systemic estrogen given her concerns for topical estrogen, and there is potential for testosterone, but I don't routinely offer this, and given that the overall evidence is a little bit limited for her. There's also vaginal laser therapy, which does have some promising results, although they're somewhat preliminary as far as efficacy and cost as far as insurance coverage goes. And then, yeah, I'm going to stop there.
And I think I agree. In the exam, I would stay away from vaginal laser because I think ABOG and ACOG are not big fans of it.
Sure.
Testosterone, I like that you mentioned it and you sort of bounced off it because it's not FDA approved for this indication, and there's limited evidence about it. Are there any FDA approved pharmaceutical agents that you could use for this woman if she cannot or will not accept estrogen?
I'm blanking on them now. I know there's like the DHEA, but I don't think that's
good. That is one. That is actually an important one. Yeah. Can
very
you tell? I'm just asking.
probably.
Could you tell us anything about that? That's one of the two.
So that is essentially in line with the idea that DHEA can then be converted to androgens, which then can be converted to essentially estrogens.
Right. Yeah.
Yeah.
Yes, I would know. There are two to know here because I think this is a very common topic in exam, and I've seen a couple of prologue questions about this in the past set. So the vaginal DHEA is obviously an inactive steroid precursor. It's just a little ovule that's usually inserted daily, and it is converted only in the vaginal epithelial cells, and it doesn't go anywhere else to androgen to estrogen and testosterone. So it's very nice for healing. It takes a little time to work, but apparently zero systemic absorption because the conversion only occurs in the vaginal epithelial cells. So it's about as localized as you can get. How about there's a SERM, a selective estrogen receptor modulator involved. Are you aware of that one at all?
I believe it's ospemifene.
Ospemifene, yes, ospina, very good. Yes, is that something that you might consider for this patient?
Not necessarily for her, given her significant concerns with any sort of estrogen. I know it's a SERM, but it could have potential other effects that she's concerned about.
Right. Well, how would you counsel her about what ospemifene could offer her and how would you counsel her about potential adverse effects or risk with it?
I unfortunately I don't recall which
Okay.
estrogen receptors it stimulates and inhibits.
No, that's okay. It is a useful one because it is actually non-hormonal. It's a SERM like tamoxifen or raloxifene Avista. It does not really particularly have endometrial effects, and it does not particularly have breast effects either. It's actually really useful for treatment of genital urinary symptoms of menopause. Like all SERMs, that has a very small VTE risk associated with it. So we do need to counsel patients about that. But it is something that would be considered appropriate in people who are breast cancer survivors and such things, people who really would not accept estrogens for that reason. So I would be sure to know for the exam because I think this clearly does come up. The SERM, ospemifene, and the vaginal DHEA. If you go on the FDA website at fda.gov, there are some excellent monographs about each one of them. They're about 2 or 3 pages long, but it's just a beautiful nugget summary of what you would need to know on that for the exam. And they're both what ACOG and the FDA says that each of these is an appropriate substitute for a woman who has this medical problem and cannot or will not accept estrogen, and they are FDA approved for both.
Okay.
So I think that'd be good just to check into. That's a good nugget for the exam, and it seems like that's the common topic of discussion. Good. Matthew, thank you for letting us go through that. That was really important to discuss sort of where they go with the well woman exams and also just to talk about the GSM issue. Is there anything you'd like to add or just any questions you'd like to ask about this one?
I mean,
yeah.
would I didn't necessarily include the fact that we hadn't, ruled out candidiasis, bacteriovaginosis, anything like that. Do you think that would be a red flag? Because elsewhere on my list, I do have some of those things that, diagnostic procedures that include testing for that. Would you consider that a red flag, or would that just
No,
be a topic point of
no,
discussion?
it's just if they bring it up, you're obviously going to say, "Oh, yes," and yeah, you did a very nice job describing it. Yes, of course, I test. That's part of my standard evaluation with my
Okay.
physical exam. And the patient declined STI testing, but I would still do a saline and KOH slide, and maybe a vaginal pH assessment.
Okay.
That wraps it up very nicely. And you just sort of drop that right in the discussion, and that would be fine.
Okay. Thank you.
Great, thank you, Matthew. Thank you again for coming up. Excuse me, get that out of the way. 2 nights in a row. Let's see. Let's go back. We are still got a little bit more than half the hour to go. Anyone else who would like to step up? Please do just click the raise your hand button. And let's see. We're doing nicely because we've had candidates who actually have had their case lists up here for us. Let's see if Dr. Kaja good. Anam, would you join us? Because you do have a case list there. Oh, hi. Thank you. Can you hear us okay? Hey,
Yeah,
thank you.
can you hear me?
Yes, I am good. Yeah, would you take a few minutes maybe, and we can just discuss anything on your case list you'd like to, a specific case or just something at random. And you could,
Can we do something on office as well?
yes, of course. Get it right here for
And
there.
then
All right, got your list.
I'm open to whatever on there. I'm peds gyne, so it's very peds gyne
Oh, I
heavy.
have noticed this. Yes, and they're going to not spend too much talking about Mayer-Rokitansky-Kunzer-Hauser syndrome. That will generally not come up. Let's see. Actually, sorry, hang on just a second here. I think we got a 14-year-old here, and it says concern for endometriosis. Can we talk about this case for maybe a few minutes? I think
Sure.
this might take the examiner's attention, just because of sort of how we think about, how endometriosis develop, and is that something we can diagnose in a 14-year-old? So I think they would ask you about a case like this on the exam. There's
Okay.
let's see, one chance in 2 or 3 that they're going to pick this one, and they would say, so tell me how did this patient present that you actually thought in a 14-year-old, gee, could this be endometriosis? And then they would just listen to how you describe it. So go ahead for just a minute.
Sure. So whenever we in peds gyne, we'll get, obviously I see adolescents. So if they come in, it's typically going to be with dysmenorrhea, plus or minus heavy bleeding. I would say most of the time they do have heavy bleeding as well. And typically I will assess kind of what their dysmenorrhea is like in terms of days of school that they miss, if they are not hanging out with their friends, staying home from activities. So that gives me an idea of how severe their pain is in terms of how it's affecting their quality of life, because that's important in an adolescent, obviously for adults as well. But really missing school is a big one for them.
Yeah.
And then I usually also ask about family history, because there is a 7 to 10-fold higher risk for girls that have first-degree relatives with endometriosis.
Yep.
And then I assess like if they have used any sort of conservative measures. Typically my patients are referred from their pediatricians, who are usually really good about getting them on to the conservative things like scheduled NSAIDs, heating pads, and sometimes they'll even start them on a oral contraceptive pill as well before they come to us. So depending on where they are on that spectrum is where we'll get that concern for endometriosis. So when I get concerned is if they are missing school consistently every single month with their period, if they're saying that NSAIDs or Tylenol don't do anything for them, if they have the family history, and if they did try a pill, whether it was even for just a month and they don't feel like it's done any sort of improvement for them, then it kind of just raises red flags for me.
Okay. So what would your differential diagnosis be in a patient like this?
So you could have just primary dysmenorrhea. You could have an ovarian cyst or ovarian mass of some sort. any sort of GI causes as well. IBS, constipation are big
So,
ones.
no, so we're talking about this would be, you're describing this as dysmenorrhea as the primary symptom in this patient?
Mhm.
Okay. All right. So GI etiologies cause pain that would seem to be dysmenorrhea?
I would say constipation
Yeah.
can
Yeah.
sometimes get exacerbated by it.
Yes, and IBS stuff also. Yeah, it's, especially for a younger patient who may not be able to verbalize or sort of
Right.
out for herself. Well, yeah, the pain, that cramping that's associated with it absolutely could be. So I'm glad you brought that up. Yes, carry on. This is, I think we're getting a good differential diagnosis here.
Um, let's see, any sort of like muscle pain, like musculoskeletal issues like
Yeah,
fibromyalgia as
yeah,
well.
good. Anything else?
Um, sometimes I'll see these kids that have urinary tract issues, whether that's frequent UTIs or voiding dysfunction as well, and they can
Yes.
sometimes they will describe that as pelvic pain or dysmenorrhea too.
Good. I think that's important also. Yeah. As far as gynecologic etiologies, is there anything else you want? You've hit primary dysmenorrhea, but I think that's the only gynecologic etiology you mentioned.
Um, I said ovarian cysts as well, and then
Sorry,
of
you
course
did. I apologize. You did, yes.
it's okay. Infections too.
Ooh.
Um,
Uh-huh.
that can happen as well. So any sort of like sexually transmitted infection, or even if it's just like BV or yeast too.
Okay.
Although it wouldn't be just dysmenorrhea, that would just be more general pelvic pain.
Okay, sure. What else? You've got endometriosis on here. Should we put endometriosis on the list for this
Oh
patient?
yeah.
Okay, sure. Anything else? You get so sick of them in the exam saying anything else because they just all the time. But sometimes it means they just want to probe you to think of you one more thing. And I just noted, I mean, given your field of practice, there's one thing you might want to mention that most people would not come to mind. Could a type of congenital uterine or lower genital tract abnormality
Sure.
cause pain?
So I mean, if they have any sort of obstructive outlet
Yeah,
anomaly, it can
yeah,
cause that. But I mean, if
yeah.
they're having periods,
Sure.
I
So
mean,
it
I
have
guess
to,
if you
or
have
it would
like
have
an
to be
ovarian,
partial
yeah,
obstruction. It could be a part. I think that's a
yeah.
good one to mention also. Good. Would you go into things like ligamentous varicosities or pelvic congestion in a 14-year-old?
I wouldn't, and I
No,
haven't.
that's fine. Good. So I think then the key question the examiner wants to come to for you here is, so it looks like you're on the right-hand side, you're considering a laparoscopy for this 14-year-old. At what point in your workup, how do you decide when it's time to do a laparoscopy based on the differential diagnosis you just gave us? And how
Um,
would a laparoscopy specifically help you here?
so typically, I'll trial them on two different hormonal medications before kind of going down the route of laparoscopy, because at that point, I think it's important for their mental health to confirm a diagnosis, because it
Yes.
gives them a lot of validation when they know that they're being heard and there's a reason for their pain. So the laparoscopy can obviously serve to help confirm a diagnosis, validate their concerns. And then in our patient population, we have seen that fulguration does alleviate their symptoms, especially when they continue hormonal methods afterwards for suppression.
Yeah, true. True. What the examiners are listening for here, though, is you in your differential diagnosis, you went wide. We went beyond gynecologic etiologies,
Mm-hmm.
which I think was a good idea. But the examiners want to hear you talk about sort of when you're thinking about where to place a laparoscopy. And this is true for all of us in
Mm-hmm.
the GYN case list as well, in particular. When we're deciding to do a laparoscopy, especially for pelvic pain, we need to be really pretty sure that the top things on our list are really gynecologic and not non-gynecologic.
Mm-hmm.
Otherwise, we shouldn't know by sticking a scope in there. We need to have the GI and urinate
Sure.
people. So I would add in here that I would do a laparoscopy when I really move to the side non-gynecologic etiology. So those are the
Okay.
compartments talked about, and they might ask you then about musculoskeletal GI stuff for a minute.
Gotcha.
But I would put
Okay.
that in. The other important thing
Okay.
is we're doing laparoscopy. We have to remember that laparoscopy is only visual. So you do have a pretty good physical exam, and they might ask you what findings on exam, would lead you to suspect endometriosis. But on your differential diagnosis, we do need to be sure that there are things for which you would have visible findings, and we often get a negative laparoscopy so that you have you want to think that you have somewhere to go if you get a negative laparoscopy here, which is why I was asking about the other things, that could be going on here, and sometimes they're non-gynecologic. So. Last question then, because you've done very nicely with it. So if I'm assuming you'll at some point do a laparoscopy, if you discover endometriosis and you do a good fulguration and you confirm the diagnosis, how would you continue to manage this patient after the laparoscopy? What would your ongoing care consist of if you're going to be her primary provider in this regard?
So typically I will have them continue on a hormonal method of whatever they're choosing is and what's kind of historically worked for them. So that could be a combined pill or a progesterone only pill. A lot of our patients will also choose to get a IUD placed at the time of laparoscopy since they are adolescents and don't always want to be awake for those procedures or insertions. So we'll do it at the same time. And we have had pretty good success doing IUD plus a pill on top of that in terms of pain management. And then typically we still encourage them to do NSAIDs as needed, TENS units, heat packs as well. And I usually see them depending on how their symptoms go, initially like every 3 months and then spread it out to 6 months and then a year once they're in a good place.
Good. Sounds good. I think the one question the examiners might want to know, though, is if on your adjuvant medical treatment you still didn't have a satisfactory or complete response and pain was still persisting, where might you go with that?
Usually then we'll consider gnrh agonist, whether that's Lupron or Cineril.
Good. But I think that's the perfect place to go. We might want to think about going back to the other compartments, but the one thing about gnrh agonist is if it's gynecologic, you will usually ameliorate it, and it's a really good test for whether it's GYN or non-GYN. If it doesn't get better on a gnrh agonist, we kind of need to get other people involved. Probably that's perfect. Good. And thank you. This is actually, I think, a very useful discussion. A lot of stuff that's really important because most of us have endometriosis on the case list. And that is kind of where the examiners wander. They're interested in sort of having us describe what findings on history and physical exam sort of, prick this up to the top level diagnosis. And they're really interested in where do we place the laparoscopy in our evaluation and how do we decide that it's the time to do that? And I think you walked through that in a very, very cogent way. That was nice.
Awesome. Thank you. So I should, when I go through the workup, be sure to, because I do usually have them go on like a bowel regimen. Oftentimes they are already plugged in with GI and other subspecialists. So should I mention those things as well?
Yes, especially because you're a little unusual here. The average primary care provider would not have somebody you're getting the people who are more difficult. Be easier to manage. Single medical therapy would probably work. It might not be endometriosis. A laparoscopy would be pretty unusual in the generalist population in this patient. A lot more for you because you're getting the difficult high risk referrals, and I would bring that up right at the your discussion. And I would say because this is a generalist exam, and when you're doing sort of specialty stuff, you always want to go back and say, now, I realize that I'm not doing what a generalist did, and I understand that a generalist would probably approach it this way, but here's what I did.
Okay, perfect. Thank you.
Good. Thank you. Nicely done once again. Great. Over for a moment. Good. Thank you. No, that was great. Let's see. Anyone else who would like to participate, please do just click the raise your hand button. Let's see. Matthew, you have your hand up. I'm going to check and see whether it was still up from before, or did you want to talk about something else?
I just had a quick question about that.
Yeah, please go ahead.
I know that was a little more subspecialized care for an adolescent or
it really
younger patient. But for generalist practice, I reserve laparoscopy if they failed essentially that kind of extensive first line management. Would you say that would be a reasonable, I've only done it really once or twice, resorting to laparoscopy. Would you say that would be a reasonable method after they failed OCTs? It would.
I think in order to do a laparoscopy in an adolescent, and I think, and I'm going to sort of chime in if you'd like to. We want to be careful about submitting adolescents conservative. Yeah, we were really conservative. So really good. So this is where my history and physical exam would be important. She talked about the first one, that family history is important. What do you feel on the exam? What could you talk anatomically? The cervix, cervical ligaments, fornices, uterus structures. How do they feel? What elicits pain and what doesn't? We want to get down to very fine anatomic structures and localize the pain. And does that line up to endometriosis? And then I want to try at least 2 good, agents. A combination OCPs and an NSAID. I might actually want to do maybe a trial of a Depo-Provera injection, something that really suppresses menstruation and is progesterone dominant, and try that. I would really try to go for a while before I did a laparoscopy. And if we're not getting anywhere, I would then start to think about other compartments. And if that weren't really revealing, then we might talk about a laparoscopy. And I think for a generalist, that's a reasonable way to walk through it that the examiners would definitely accept.
Okay. Okay. Thank you.
Good. Thanks. That was great. Let's see. Oh, good, Dr. Arando. Thank you. Just going to get you unmuted here for a moment. Just click the audio button and we'll be all set to go. There you go. Thanks. Hi, welcome. Thank you for joining us. Can you hear us okay?
Yeah, can you hear me okay?
Oh, yeah, we're great. Thank you. Let me just bring up your case list. Got it right here. Just lead me wherever you'd like to go on your case list. Any particular part of your case list or topic?
I think I'll go with office as well.
That's fine. I don't mind that at all. Office gets not so much in these webinars, so we're always happy to talk about office. It's the least
because I feel like I have a broad number of topics, I'm sure, as everyone else does.
Yeah.
The one, let me see, there's actually probably a couple that would be fine. So if you see one that's interesting, feel free to call it out.
Yeah. Was there one you wanted to direct me to? Because I'll be happy to go there as well.
I was trying to see, I have a paper copy in front of me, but I unfortunately don't. There was one on an adnexal mass. I think I have a couple, but I just need to find.
Let's do that because we haven't talked about adnexal masses yet. That would be a good topic.
Oh yeah, 31 and 32, either one of those. I just feel like that's a tricky one for me.
Yeah, this is a good one. Do you have a preference? This is actually a really nice way to set up your case list because you've got a elderly postmenopausal woman, sort of older, and then you've got a young reproductive age woman, and that's nice for compare and contrast. Would you like to pick one or the other to discuss? Do you have a preference for the younger woman or the older woman?
I'll do the older one.
Okay, that's fine. So let's do that. So 69-year-old, let's say I'm assuming you were her primary care provider, felt something on exam, and you got a CT scan, and it shows a left ovarian cyst. As the attending gynecologist, how would you then proceed to evaluate that? What would be the important things that you would want to do next?
So in her case, since CT scan is not typically first line in terms of evaluating for an adnexal mass, I would order a pelvic ultrasound just to better characterize, whether it's truly there and to assess, where exactly it's arising from, and then characterize the features of the adnexal mass as well. And then tumor markers as well, and then a good history and physical. We already mentioned the physical exam, but I think a history as well would be important.
Good. I think starting with the history is good, but I like that the first thing out of your mouth was that CT is not, as gynecologists, how we can really characterize adnexal mass as well. You want to go to an ultrasound. We get better as for cystic adnexal masses. You're absolutely right. I put that out there first. And then history. So about history, what you tell me just very focally, what are you thinking you want to know about history for this patient?
So for history, I would like to know whether or not maybe there are genetic or other risk factors that would increase the risk for malignancy. I think that would be important. So family history, personal history, genetic history, and then also maybe if they comorbidities. So for example, if they had a prior history of some sort of cancer, that would be important. If some of these patients, when they come, they'll mention, especially at the age of 69, they'll mention that maybe they've had prior imaging and they've known that they've had an adnexal mass. So kind of clarifying that as well.
Good. I think that's a good place to start. So and then on physical examination, just tell me very briefly, if you were examining this patient and you wanted to find out about the cyst, walk me through your physical examination. Exactly what sort of things are you feeling, and what are you trying to learn about this, about the adnexal mass? Sort of what things are you feeling for?
On physical exam, I would try to feel if it's mobile, if it's fixed, if it's tender.
Mm-hmm. So mobile versus fixed, tender, I think both very important. Anything else as far as sort of the...
On physical exam, I guess also to make sure that it's not potentially arising from maybe another structure.
True. Is it
Like
confusing?
if
Could it
it's
be maybe a
vaginal or
pedunculated
something.
myoma instead of, yeah, could it be something that's not
Mhm.
coming from the adnexa? Yeah. On an exam, could you get an appreciation as to whether this might be cystic or solid? Is it possible to do that?
It's possible, but I think that it would be difficult. It would be pretty difficult unless it's very large and the patient is very thin. I think that would be a difficult distinction to make.
Good. So we're coming to that. The other thing I would really want to mention early on is part of my pelvic exam is I want to know the size of this. So I think
Yes.
size would be up front, and then yes, does it feel soft and cystic? Does it feel nodular, firm, solid? Do I have any concerns for malignancy? Is it fixed or mobile? Is it tender? I think that's perfect. I think that actually wraps up everything on a physical exam that kind of would be important then. Now, one thing I would like to mention to all of our candidates is on the GYN case list, really critical. On the office practice case list, pretty much too. We do want to characterize the adnexal masses. So when we mention a adnexal mass, the examiners want to know three things. What side is it on? This is on the left. How big is it? It's 2.8 centimeters by ultrasound. And then how do we appreciate its significance? We want to use words like simple, complex, septate, solid, feature suspicious for malignancy, excrescences, mural nodules. You can take words right off the ultrasound report, such as suggestive of endometrioma, suggestive of cystic teratoma, consistent with hemorrhagic cyst. Those are the things that help the examiners to sort of figure out, and particularly on the GYN case list, why you might be choosing to operate on these things. And it's important, if you haven't written that on the case list, just to throw those words in there. But those are all really important. So in this case, let's come back to, we've got the ultrasound, and do you recall if this was simple, complex, any particular characterization?
Yes. On ultrasound, it was a simple cyst.
Simple cyst, great, good. So then tell me, so what's your differential diagnosis? 69-year-old comes in with a 2.8 centimeter simple cyst of the left ovary. Was she symptomatic for this?
No, she was not.
No, asymptomatic. So what's your differential diagnosis here then?
I guess the differential would be a functional cyst.
I agree. Yes.
As far as other things, I mean, if we don't know, I think the pelvic ultrasound is helpful because sometimes it can be a hydrosalpinx, as opposed to like an cyst that's arising from the ovary. It could be related to also sometimes on the CT scan, if for some reason they cannot assess that whether or not it's coming from gynecologic organs, if it could be related to GI etiology, such as like a diverticulosis lesion.
We could throw that in there, although I think I would stick with gynecologic. What we are teaching in our courses these few months, and what we should talk about here is in the exam. I would suggest there are basically three categories of adnexal masses, and they are physiologic or functional things. They are benign neoplasms or they are malignant neoplasms. And in the exam, we want to kind of just mention briefly, acknowledge the possibility of a malignancy, but I would want to bounce it off and keep the discussion back to those other two categories, physiologic or functional and benign neoplasms, because the vast majority of masses that we see in our practice are that. They are not Sertoli Leydig cell tumors or something bizarre like that. So we have maybe a functional cyst that's left over. It could be a paratubal cyst or hydrosalpinx. It might not be from the ovary. It could be hemorrhagic cyst. 69-year-old not likely to be an endometrioma. And then you'd come to certain neoplasms. Is it possible that this is a benign cystic neoplasm of the ovary?
It is possible, yes.
It is. If so, what type of variety would you expect it to be? What the examiners will, they'll ask questions in exactly this order, pretty much.
Okay, along the lines of like a cysticadenoma
There you go.
potentially.
Right. So epithelial or germ cell in a 69-year-old with a simple 2.8 centimeter cyst, if it's a neoplasm, it's going to be epithelial germ cell. Which would you
I'm
say?
sorry, what did you say? Is it, oh, epithelial?
It'd be
Epithelial given.
epithelial. So it'd be
Yeah.
yes, so it'd be cysticadenoma. Good and possible. I mean, all cystadenomas, I think, at some point in their lives are 2.8 centimeters. We might be catching this thing really early. It's possible. And I would say now, though, malignancy is always a possibility, especially in an older woman. But with a simple cyst, that's not likely. And I really being asymptomatic and with a normal exam, I'm confining my discussion to keep it over on the other side there. So that brings up then, so why did you check tumor markers on this page? The examiners always want to know that, because it's small, she's asymptomatic for this thing. It's simple on the ultrasound. It really sounds pretty innocuous. Why did we check tumor markers? And which ones did you check?
In this case, I checked a CA125, CEA, and CA19-9.
Good.
Although the cyst is simple appearing, tumor markers can be helpful for risk stratification.
Very good.
And can help with determining the follow-up plan.
Very good. Yes, because if this is a cystadenoma or mucinous or something like this, serous or mucinous, you could actually pick up a low-level elevation of a tumor marker, and that would affect your management. So that's fine. In a 69-year-old woman, that is fine. In the 28-year-old woman, it'd be hard to justify. But no, you're fine there. You described that very nicely. You picked exactly the ones because you're looking for epithelial neoplasms, as you said. Good. So it looks like, we'll wrap up here in a minute. It looks like your ongoing care then is just to watch this.
Correct. Plan will be for surveillance, potentially 1 year follow-up, and if it's stable, then from there, just clinically.
Great. So here's a really important exam question. So then if you're going to do your surveillance, how long are you going to wait to follow up your ultrasound?
6 months to a year in this case, because it's small and simple appearing, I would lean towards a year.
Let's go with a year. So if you're going to check it in a year, what findings on the year follow-up examination would make you recommend surgery to this patient? What particular findings that would change here a year from now would make you recommend that this should actually be a surgical case?
If the cyst has gotten larger, if there are other findings that are concerning for malignancy, that could have to do with characterization of the cyst, as well as things such as evidence of like metastases, things like that.
Good. So if it gets larger, definitely. If you see signs concerning for malignancy, absolutely. So that's two. Let's see. And so that's. Did you mention anything else in there? There are 5 things I think we want to mention here.
You
it
talked
all
about
has
it
to do
being
with
larger.
I'm going to say that again.
It being larger.
Right, increase in size, signs concerning for malignancy. Right, so bizarre features, signs of metastasis. That'd be good.
I guess should the patient become symptomatic?
Yeah, he goes from asymptomatic to symptomatic. She automatically at her age gets operated. Very good. We're up to 3 there. That's actually very good.
There's
actually 6. There's actually 6 things. Sorry, we're doing good. We got 3 of them out there. So while the signs concerning for malignancy is sort of an extreme variety of that it changes its character. So it goes from simple to complex, or from simple to septate, or develop something else like that. So changing characterization on ultrasound would be important. So it gets larger, it changes its character. It specifically develops signs suspicious for malignancy. She becomes symptomatic. And then there are 2 more things here, and one of them you actually have already written up here on your case list under the diagnostic procedures.
The tumor markers.
The tumor marker turns positive. Tumor marker turns positive. The 6th thing I would add in there is if a year from now it's now bilateral, would that lead you to operate on her?
Yeah, potentially.
That's an increase in risk of neoplasm. Yes, if she's
Yeah.
now, if she's got a normal right ovary, and a year from now she's got a similar cyst on that ovary, then in a 69-year-old, something's developing here. 69-year-olds don't develop new functional cysts, really. So the increased chance of malignancy, operation. Good. So increase in size, changing in character based on your ultrasound characterization, specifically signs suspicious for malignancy. Patient becomes symptomatic. You develop bilateral masses on your ultrasound, or a tumor marker turns positive. That's the really good thing, just to remember that you spit 4 out of 6 of those out and you'll be fine on the exam. But those are all the things for which we would turn around and do surgery. Good. And the other question on the exam is, but hypothetically, what findings on this evaluation would lead you to recommend surgery rather than observation? And that would be the same list, except that it's not an increase in size. Is she symptomatic? And is there a size limit, a particular size in a 69-year-old at which you would automatically operate on her?
If it's simple appearing, then typically it's 10 centimeters.
10 centimeters. Now that's usually in a 69-year-old woman, would you go with the 10 centimeter rule? If it were 7 centimeters and apparently simple, how would you feel about that?
If she's asymptomatic and it's simple appearing, I would counsel her. And if she wanted to, especially given her age, if she wanted to avoid surgery, I think that we could watch and see.
Okay. And the examiners are going to come back with how many 69-year-old women could actually grow a completely physiologic 7-centimeter ovarian cyst. Does that sound reasonable, or is it more likely that this is a cysticadenoma, and particularly a mucinous one, which is growing? Which would be more likely, do you think?
It would be more likely to be a cysticadenoma, but could it also be a peritoneal inclusion cyst?
Could absolutely be. You're absolutely right. It could be a large peritoneal inclusion cyst or para-ovarian cyst. That is absolutely true. But I think if you ask the GYN oncologist, I think they would tell us. And I think this is good for the exam. I think in a menopausal woman, about 5 centimeters is our cutoff for operation. In the 28-year-old woman right below you, 10 centimeters, 10 to 12 centimeters is great. In a menopausal woman, 5 or more, it's more likely to be a neoplastic than sort of a functional physiologic cyst, because they generally don't get that big, and they certainly don't develop or grow over time, which that sort of thing would have to do. That sounds neoplastic. So I would use the 5 centimeter rule in the 69-year-old woman. I think in the exam you'll be conservative and very safe.
Okay.
Good. Oh, good. That was a great discussion on adnexal masses. Thank you, Choma. We got a lot of work done there. Anything, we do have to wrap up in a couple minutes here. Anything you'd like to ask about this case, or would you like to add any other particular comments? That was a really nice, I think, thorough discussion there.
No, that was very helpful, because I've been struggling and thinking through that one. So thank you.
So on the GYN cases, that is exactly where we want to go, because we're going to be operating on these things. And on the GYN cases, the examiner is going to ask, so why did you operate on them? And you go through the same list and tick off the positives. On the office practice case list, why did you continue to observe it? Is you go through the same list and you say, well, none of those 5 or 6 things were present. And then if you watch it over time, what leads you to operate? It's any one of those 5 or 6 things turned up. And those any one of those that we talked about is an indication for surgery in a 69-year-old. Good. Choma, thank you so much. That was really nicely done. We do actually, that was a quick hour. We do need to stop already. We will be continuing on then. Tomorrow, of course, being Wednesday, one of our faculty will be here with us. We will be doing structured cases again. We'll continue on Sunday, Tuesday is case list review, and Monday, Wednesday is structured cases. So for all of you who are participating, if you can, because you'll be submitting your cases, do send up whatever you have to the ExamPro website. It's support@exampro.com. Even if you're doing the late submission and your case list is not complete, do feel free to put it up here, because then we can participate and you can use your case list as it is and you can talk about anything you'd like to. So please do go get those in if you could. For now, thank you again. Have a wonderful rest of the evening, and one of our faculty will be back tomorrow and we'll carry on again. Thanks.